Good morning, everybody, and welcome to the webinar. My name is Emily Cosick, and I'm the Knowledge Manager at the Canadian Institute for Public Safety Research and Treatment. It's my pleasure to be hosting this event made possible by a partnership with the Canadian Institutes of Health Research. Today, we are going to continue our series on research done for the Post-Traumatic Stress Injuries and Public Safety Personnel Catalyst Grants. There are a few housekeeping notes to do before we go through the presentations. So first of all attendees are in listen-only mode. This is to limit the feedback and ambient noise from the session. Today's session is being recorded, so if you missed something, you can certainly watch it again later. Those recordings will be sent out to you. We ask that everybody use the question box to ask any questions for the presenters, just because we are in that listen-only mode, and that means that I'll be the one asking the questions on your behalf. We are going to be leaving all the questions till the end of the session after each group has presented their research. So just keep that in mind that it'll be at the end of the session that your questions are being answered. Last thing I want to mention is that some organizations do block the GoToWebinar app. This means you may have to join us by phone, but again, that recording of the session will be sent out to you in case you can't see the slides. I just wanted to let you know lastly that I've also attached handouts for this session. In your control panel, you should find 3 handouts. These include the agenda for today and English and French versions of the presenter's knowledge translation reports. These handouts will also be posted on our website tomorrow, along with the recording of today's session. So if for some reason you can't access them now, they will be available on the website tomorrow. So now I want to go ahead and introduce our first project for today. The project title, it's a long one, so bear with me, is an interdisciplinary and mixed methods analysis of the Correctional Services Canada Academy's 13-week correctional personnel training program, building a toolbox for correctional officer mental health and occupational success by identifying ways to optimize the impact of training for public safety personnel. So that is going to be presented today by Dr. Rosemary Ricciardelli, Professor of Sociology at Memorial University in Newfoundland, and Dr. Sylvain Mongrain from Correctional Services of Canada. So I am just going to go ahead and turn over the presenter control to you, Rose, and you should be good to go.
Everyone can see my screen?
Yes, yes, we can.
Okay, so I'm presenting today with Dr. Mongrain. The correctional officer, I'm sorry, Emily, I can't actually see my screen. You can see it?
Yeah, we can see it. Yeah. Oh, we just lost it for a second there, but we can see both. We can see 2 screens now. So we could see the full screen before, but now we can't see. We can see both screens, I guess. So I don't know whether you want to put it in presenter mode again.
Trying. Okay, so an interdisciplinary and mixed method analysis of the Correctional Services Canada National Training Academy's Correctional Training Program. So in this, for the current presentation, I analyzed my field notes and participation experience as I completed 3 stages of the Correctional Training Program, CTP, including the 14-week in-person component where I spent time being there. Dr. Mongrain will speak to the values and ethics components of CTP, after which I will unpack the socialization experiences of training to become a correctional officer, CO, for the Correctional Services Canada. Sylvain, Emily, I can't see my screen at all, so I don't know where the PowerPoints are doing.
Sure, so you're just on slide 3. I think you need to move to the next slide.
Okay, so slide 3. So I will be responsible essentially to give you a bit of information on our correctional training program. We'll talk about the academy a bit and the values and ethics component of our training. So I will be brief, but you know, if you have any questions, please send the question to us. So I'm on slide 3. So if you want to work as a correctional officer in Corrections Canada, as a primary worker in our women institution, or older brother, older sister in our Healing Lodge, you must pass a training called the Correctional Training Program as part of a selection and appointment process for those employees. participants in the program are referred as recruit. So the program ensures really the recruits to acquire fundamental skills, the knowledge, decision-making skills to assume all duties of their position before they are hired by CSE. As such, recruits are evaluated throughout different stages of the training program, including values and ethics. I'm on slide 4. CPP is a 3-stage training program. The total number of weeks is about 20 weeks in duration. The first 2 stages are done at home. During those stages, candidate will go over fundamental knowledge and information on the basis of which they will be reviewed and knowledge and skills will be applied in stage 3. So stage 3 is really an applied stage. Stage 3 is 40 weeks, and the training is happening at the National Training Academy in Kingston. The training is intense in stage 3. There's significant amount of learning that needs to take place. So it's that stage where we bring them really to the reality of the job. Overall training approach is influenced by field of neuroscience applied to learning. So content is often broken down into small parts, dispersed throughout the training so that we can respect key principles like repetition, like progress, and building on success. Training sessions are usually quite interactive, where the participants play an active role in the training. We also have quite significant time where the recruits are being asked to apply what they have previously learned, facing realistic operational scenarios that are based, a number of them are based in reality, in fact. So the training is happening in a realistic infrastructure environment, so to speak. And this is really to increase the chance of transfer of those skills into the work site or our institution. In terms of the content, majority of the training is to learn and practice all aspects of our security intervention model. Communication is a fundamental competency that we spend a lot of time on, and this is linked to the day-to-day job of a correctional officer. Training will also teach tools and skills related to the application of our use of force intervention, so self-defense, risk and control, and weapons. Decision making, like I said, a big focus in the training. So recruits will go through over 70 different type of scenario, going from more simple to complex. We'll talk a bit about the training academy. So training is provided at the academy. Original location of the academy was in Regina, in a partnership with RCMP at the depot facility. We have since relocated in Kingston. CSE have created the academy in 2013. So all of the recruits trained in to be correctional officer are going through the facility. For decades, the training was offered through different learning centers across the country. It's now centralized. Obviously, because of the COVID situation, we had to be quick on our feet and make some adjustment to our training strategy. So we are offering training in 4 other sites: Abbotsford, Saskatoon, Port-Cartier, Summerside, and PI. This strategy offers an opportunity really to limit or reduce transmission of COVID and meeting the demands of CSE. At the academy, we are teaching about 100 years of experience in corrections. Philosophy of the training academy is based on a human, constructive, and positive approach to learning. We are dealing with human beings at our institution, and we need to teach and reinforce our recruits to react in a constructive and human way on the basis of our core value, which is fairness, respect, professionalism, inclusiveness, and accountability. The behaviors that we want to see at the academy are the behaviors that we want to see in the field after that. So in order to do so, we carefully need to select our management team and our trainers to work at the academy. I can ask more questions about how we're doing that later. This is some visual of our academy, as you can see. Fairly realistic. It's a temporary place that we are in right now in Kingston, but we're going to move eventually to more permanent location in Kingston. Values and ethics. This is formally part of CTP. We teach our core values to help our employees to perform all of their duties and contribute to CSC's mission. Our teaching on values and ethics is based on our mission and our policy, mainly Commissioner's Directive 001 and 060. Formal and structured training on values and ethics is part of all stages in CTP. So our approach to teaching values is progressive, like many components of in CTP. Stage 1 and 2, where we have it's an online component where we have our own information and knowledge prior to come to the academy physically. We are introducing values and ethics at that stage. In stage 3, they are first being discussed in the first week. Recruits are coming from the street for most of them, and we expect some level of misunderstanding or some adjustment, the way they talk, the way they interact, the way they work as part of a team, overall attitude towards certain situation. So we expect some adjustment, and we're there for that. And we want obviously to provide an opportunity for them to succeed in that area, since it is formally evaluated as part of our of the program. In week 3, we are refreshing our core values and related policy. At that time, we will increase insight by providing them the opportunity to discuss their values and even being challenged. And so for some recruits, it's really an opportunity to see how much their value align to CSC values. We're also teaching some very concrete tool when they're going to face ethical dilemma at the workplace. The application of those learnings are mainly taking place during scenario training. Scenarios will challenge them on their values as they will face operational but fictional but realistic scenarios. They will be asked to intervene, facing different type of scenarios, including mental health issues, violence, degrading comments, irrespectful behavior, lack of fairness, loyalty to the team as part of a subculture. Of course, formal evaluation is taking place, but our recruits are and also formally evaluated on their behavior and attitude, and could be released on the basis of that. So it's a very important part of the training program. So we provide our recruits a concrete guide, a guide that will help them understand the expected behavior, that will support CSC's values and attitude and CSC's code of conduct. We evaluate 5 components: so dress and deportment, standard of professional conduct, respect of some specific rules in CSC at the academy, and behaviors that reflects ethical work and attitude and behavior that will be contributed to a positive and constructive learning environment. For each expected behavior, we have clear indicators, and so we are asking the recruits to review this guide on a regular basis and to self-evaluate themselves on that. We have also significant teaching that is done informally at the academy. So from the outside, when we look at the academy, it could be a place where we can see where we have formal teaching through a series of very structured lesson plan. But academy really is a living environment where groups and people, so recruits and staff, are interacting, adapting to programs, social situation, incidents, adapting to change. And so the academy from that perspective is really richer from just the formal teaching on values and ethics. So we take opportunities of event situation that will happen at the academy to make some teaching point. And there's a lot of the adjustment done on values and ethics from those type of teaching. So the academy is 24/7. Recruits are staying at the academy for the 14 weeks of the training, And things happen, not only during the daytime outside of the training, but also at night and during weekends. So we take certainly the opportunity to make some adjustments. Rose, I'm on slide 12.
Yeah, I'm just trying to turn it. Socialization at the Training Academy incorporates the element of values and ethics that are taught strongly. So for clarity, when I speak of training, I'm talking about the proficiencies taught and the manifest as well as formal messages surrounding each proficiency. Socialization instead refers to the informal messages taught at the academy as well as the latent lessons derived from training. Training and socialization do not simply overlap. They occur simultaneously and each informing and shaping the other. Socialization through training represents a central means through which COs anticipate their occupational work, prepare to perform their occupational responsibilities, and learn their position within the organization, including their degree of occupational agency, expression, and expected commitment to their colleagues in the broader organization. So recall, organizations invest tremendously in recruit and staff training, yet without an examination of socialization within the academy, the outcomes of training, intended or not, are ambiguous. But little research exists on how COs are socialized through their training or once working within the institution. So here I'm going to use Van Manen and Shane's typology, their theory of organizational socialization, to understand the socialization process inherent to the structure of the training academy, while noting the key elements of informal socialization recruits experience. And specifically, I'm going to focus on the role of ethics and values. So the typology rests on 6 socialization tactics, each producing different role orientations, degrees of ambiguity, and conflict among recruits, as well as variance in job satisfaction, commitment, and occupational leaving. Collective tactics, for instance, are common learning experiences designed to standardize how recruits respond to situations and thus socialize recruits to accept the organizational standards tied to the occupational role. Individual socialization tactics, on the other hand, allow for heterogeneity in the responses of recruits by providing unique learning opportunities rather than standardized, which allows for more innovation in how recruits adapt to the occupational role. For large organizations like CSC that hire many new employees at one time, training programs at an academy often occur prior to starting the job. These programs are instruments of organizational socialization, and they're invested in because training processes support employee organizational occupational adjustment, as well as attitudes and behaviors. The CTP is of undeniable importance, as it's in CTP that recruits are formally trained for their occupational role and informally socialized into the occupational position. So reflecting on the typology, the training environment at the academy uses formal, so recruits are separated from the employees; fixed, they adhere to a timetable; sequential, where they're informed about their occupational role; collective, in that it's common learning experiences; and serial, trainers are all experienced COs, socialization tactics. The expectation is for the trainers at the academy to perform as role models for the recruits, while the academy socializes recruits in a manner that encourages standardized responses when approaching situations and promotes organizational commitment. But there's an individual caveat, and this is really important. This is where the discussion of integrity comes into play. There is an exception to standardized responses in the area of integrity. Here we see institutional socialization tactics, standardized responses, but an individualized emphasis. So at the academy, the seemingly contradictory message emerges, where the academy atmosphere and lessons encourage collective solidarity and camaraderie among recruits. For example, when we're testing, we often test in pairs, we rely on each other, we work together. But there's these collective responses. There's also a reminder to recruits to remain self-focused, enforcing that each recruit is accountable for their actions or roles in the acts of others. Recruits are both to be bonded and split, on the one hand ready to protect each other and have each other's back in the institution, and on the other never to turn a blind eye towards concerning behaviors. In response, recruits appear to be socialized for what I refer to as caveated camaraderie, where recruits learn the value of collective solidarity and camaraderie, but only as far as all recruits act with integrity and abide to the behavioral expectations of the organization. What results is a sight lacing and mistrust among colleagues that nags at the level of solidarity among a cohort. So it's an environment that breeds hypervigilance and surveillance as characteristics of employees. But at the same time, the main focus always remains this idea of acting with integrity, values, and ethics, and that's essential in order to proceed through. So as long as everyone is behaving within those confines, everyone continues to proceed and you have the solidarity. If someone steps outside of that, it becomes more challenging. So underpinning both individualized and collective training practices, as well as institutional socialization tactics, is a value placed on the effective, moral, and continuous elements of organizational commitment. Just the amount of time it takes to make it through the stage 1 programming modules requires commitment to the occupation and the organization. So this reinforces that recruits are psychologically committed, organizationally loyal, and invested in CSC. So although caveated camaraderie is taught, the pressure-infused training environment produces strong bonds between recruits in focusing on both the individual recruit and the greater collective. What is really important, however, is we need research into onboarding. Does what's learned in the academy persist into the organization? So the vision of the CSC National Training Academy is to produce a standard of excellence in our graduates that will reflect the core values of the Correctional Service of Canada. This is achieved by maintaining a focus on values and ethics throughout the training program that will be maintained through officers' careers. We have also developed parade and ceremony that will inspire pride in our graduates, and that comes directly from CSC. So we see the paramount importance of values and ethics. Thank you.
All right, thank you so much for that wonderful presentation. So I am going to turn it over now to our second project of the day. So thank you again for your presentation. So our second project of the day is do cognitive behavioral therapy skills classes increase resilience-related brain connectivity and pattern, brain connectivity pattern to post-traumatic stress disorder. I apologize, I messed that up a little bit, but I am going to welcome our presenters. So we have Dr. Ko, who's an assistant professor of human anatomy and cell science at the University of Manitoba. We also have Dr. Moda, who's an assistant professor in clinical health psychology, also at the University of Manitoba, and their knowledge user, Scott Wilkinson. So I'm going to go ahead and I'm going to give presentation control over to you, Dr. Ko, and you should be good to go in a moment.
Okay. Okay, thank you. So can everybody see my screen?
Yes, yeah, we can see it.
Great.
Dr. Ko, if you wouldn't mind just going to the next slide, please.
Okay, so yes.
Oh, excellent.
Yeah, Natalie, go ahead.
Awesome. Thanks for joining us today, everyone. So public safety personnel have a higher rate of several different mental health conditions than the general population. And we think that this is because of the higher stress levels that they face on the job, as well as the higher risk that they have of exposure to a wide range of traumatic events while working. Cognitive behavior therapy is a psychological intervention that has a vast body of evidence showing its effectiveness for the treatment of a wide range of different mental health conditions. But we also know that there is evidence for CBT in preventing depression among at-risk populations. So these are individuals that for various reasons might be at increased risk of developing mental health problems, but have not yet done so. So our team a few years ago, led by Dr. Jatinder Sareen, were awarded a grant from the WCB to conduct a pilot randomized control trial to see if a class-based intervention featuring introductory CBT skills might be effective as prevention for PTSD in a sample of public safety personnel. When it comes to the neurobiological underpinnings of PTSD, we know for sure that there are brain changes among individuals with PTSD. And there have also been studies that follow patients with PTSD as they undergo psychotherapy to see what happens to the brain. But a lot less neuroimaging research had examined PTSD prevention to date. And so Dr. Ko and I were extremely fortunate to be awarded a CIHR Catalyst grant to add a neuroimaging component to what we will refer in subsequent slides as the parent study, and look at whether the brains of individuals participating in the CBT classes changed over time. And this, of course, was a sample of PSP who may have had kind of some sub-threshold symptoms of different mental health problems, but did not have any mental disorders. You can go to the next slide, please. So just to tell you a little bit about our CBTM classes, this is a 5-session intervention, 90 minutes per session. And as I mentioned before, they have been developed to be delivered in a PowerPoint format in order to be able to increase access and reach and be delivered in kind of a class-based intervention format and be able to reach kind of as many individuals as possible. And they were originally developed to attempt to reduce the wait times for patients who were awaiting psychotherapy services with depression and anxiety disorders. These classes include a variety of different introductory CBT strategies, including challenging our negative thoughts, behavioral activation, which means kind of engaging in pleasurable or meaningful activities to increase mood, in vivo exposure, which is kind of gradually facing our fears and the things that trigger us, problem-solving tips, healthy living techniques, some sleep management strategies, and then our advisory committee for our parent study suggested adding a 5th session that was focused entirely on managing traumatic stress reactions specifically, and so we added that 5th session. Go to the next slide. Thanks. So this is just a bit of a figure outlining the participants that were enrolled in the parent study. We screened 102 for eligibility, and after exclusionary criteria, we were able to randomize 60 to either participation in the CBT classes or a waitlist control. And the neuroimaging component that Dr. Ko and I led recruited from this larger sample. And so we were able to recruit 11 from the CBTM arm for the fMRI portion of the study, and 14 from the waitlist control. And these consisted of firefighters, dispatchers, and paramedics. Next slide, please. Thanks. So these are the sample descriptives of the overall larger study sample. So the mean age was about 40. There were a slightly higher percentage of women in the waitlist arm than the intervention arm, but it wasn't significantly different. And the majority were also married common law. And if we look at the next slide, oh, I thought there was one other slide. We saw kind of more or less the same breakdown among kind of the subsample of participants that participated in the neuroimaging study as well. And so before I hand it over to Dr. Ko, I just wanted to present this exciting slide. These are preliminary results. One back, please. There are preliminary results between the two groups. The blue line is the waitlist group, and the red line is the group that participated in the CBTM classes. And what we see here are changes in PTSD symptoms over time as assessed by a self-report measure called the PCL-5. And so what you'll see is kind of at the beginning of this study, the two groups were very close with regards to PTSD symptoms, but right at the end there, by the 3-month follow-up, there's a difference between the two groups in that those individuals who participated in the CBTM classes showed lower levels of PTSD symptoms, even though both groups showed low levels of PTSD symptoms overall. And I'll pass it over to Dr. Ko now.
Thank you. So the preliminary study suggests that the CBTM, the cognitive behavioral therapy with mindfulness component classes, works on the PTSD symptoms. And so what about the neural mechanisms of this benefit? So this is the study design of the study. As Dr. Mora said, that among the 60 participants, 30 individuals underwent this neuroimaging component of the study. And so this is basically when we took the fMRI, so at the baseline, and within 1 week after the last session of the CBTM classes and the 3-month follow-up. So this is what brain imagers typically do with brain fMRI data analysis. So fMRI signal indirectly reflects the neuronal activity. So let's say we take the fMRI signal from these regions, and that is yellow, and in the posterior cingulate cortex, and then we take the fMRI signal from this anterior cingulate cortex, which is in the orange, and you can see that there is some spontaneous synchronous fluctuation between these two signals. So when they are fluctuating together, that potentially means that they are communicating each other with a very efficient way. And so when there is this synchronous fluctuation, we typically assume that these two brain regions are functionally connected. So, and then we apply this independent component analysis, which is a multivariate pattern recognition mechanisms. We can identify different intrinsic brain networks. For example, executive control network is like this, and it is involved with a high-level cognitive task. And salience network is involved with monitoring threats or relevant stimuli. Dorsal attention is paying attention, of course, auditory network, sensory motor network, and visual network, and default mode network. And default mode network, the name is a little bit misleading, but it is related with self-referential thoughts or mind wandering, which is typically what people do when they are at rest. So previous studies suggest that among those intrinsic networks, these 3 intrinsic networks, salience network and central executive network and default mode networks, are abnormal in PTSD patients. And for example, salience network is hyperactive in PTSD, and central executive network and default mode networks are hypoactive in PTSD. And it turns out that the cognitive processing therapy, which is a gold standard psychological intervention for PTSD, actually increases this central executive network connectivity, which kind of makes sense because cognitive processing therapy is more of helping the patients to have a higher control over the cognition. And this present-centered therapy happens to decrease the salience network activity in the PTSD patients, which also kind of makes sense. And what was interesting to us was that the mindfulness-based therapy actually increased the default mode network connectivity in PTSD patients. And it has been further suggested that among this default mode network, posterior cingulate cortex is a key anatomical region that is associated with the enhanced mindfulness, which has been targeted by meditation. So this posterior cingulate cortex was our priority regions of interest in our analysis. And so this is what we did with our fMRI data. So we take the fMRI signal from this posterior cingulate cortex, and this is a time series of the fMRI signal. And then we search the other brain area that is synchronously fluctuating with this posterior cingulate. Remember that if this, for example, this is taken from here, I think, and if the region is fluctuating together, they are mapped as red or warm color. And if the region is not fluctuating together, they are not colored. And then if they anti-correlated, it's blue or cold color. So this map represents what regions are functionally connected with posterior cingulate cortex. And then we map out these functional connectivity map for all scans that we acquired, and we bin them according to the scan condition that they were taken. So these are the baseline scans of the treatment group, baseline scans of witness group, and the 5 week after classes, CBTM classes, and 5 weeks after the waitlist. And then we look at the interaction between these 4 across the 4 different conditions, and we found that there was increased functional connectivity in the ventral lateral prefrontal cortex with the posterior cingulate cortex, which means that after the 5-week treatment in the CBTM classes, the left ventral the connectivity between posterior cingulate and the left ventral lateral prefrontal cortex was increased only in the CBTM classes, but not so much in the weightless group. So what does it mean? So this is what we know from the parent clinical trial and also some literature. CBTM, the cognitive behavioral therapy with mindfulness component classes, may be beneficial for reducing PTSD symptoms in public safety personnel. And from the literature, we know that the ventrolateral prefrontal cortex is associated with the cognitive control of memory. And the posterior cingulate has been associated with recollection of prior experiences, especially those experiences that involve self. So, and this is what we found from our neuroimaging study. The CBTM increased the connectivity between the ventrolateral prefrontal cortex and posterior cingulate after the 5-week treatment period. So our potential interpretation of is I lost my screen. Yeah, is that the CBTM may have strengthened the cognitive control via ventrolateral prefrontal cortex over self-referential memory retrieval, which is done by posterior cingulate, and thus it may have reduced the PTSD symptoms, and further maybe it is useful for preventing the PTSD in public safety personnel. So this is the future direction. The CBTM or mindfulness-based therapy is not just about the PTSD. It has been shown to be beneficial for other neuropsychological disorders. So we are going to investigate that too. And another important issue is the long-term attrition. In fact, our neuroimaging study was not replicated in the 3-month follow-up period. So that has to be, we are working on that analysis currently now. And finally, perhaps some other techniques such as non-invasive brain stimulation technique can perhaps further increase the benefit of a CBTM therapy, because we now know where to stimulate. For example, if we can increase the neuronal excitability and increase the connectivity between the ventrolateral prefrontal cortex and the posterior cingulate, it may actually synergizing effect with when it's combined with the cognitive behavior therapy with the mindful component. So lastly, Mr. Scott Wilkinson is a participant advisory committee member of our parent clinical trial, and he graciously agreed to serve as a knowledge user in our study, and he's going to share his perspective on the impact of this study on public safety personnel.
Thank you, Dr. Ko. Happy to be here. Good morning or afternoon to everyone, depending on where you are. Yes, we were very pleased as the Winnipeg Fire Paramedic Service to be involved in the CBTM studies. Our staff, we had quite a few staff volunteer and gain the benefit of this. So both while learning from the studies themselves, we had a lot of members gaining a lot of additional insight and training to help with their resilience and potential development of any kind of mental health or occupational stress injuries. So very collaborative effort on all parts. I'm very happy to be involved in that. The successes that you've heard about, the initial positive successes that we've seen from this, I think are extremely encouraging for us in the fact that we would look possibly to the future of including this type of training for all of our new recruits, because our new recruits are at the point coming into the position where they're going to be starting to be susceptible to some of these traumatic experiences. And we all know that the results of that have been, growingly more aware of in our industry for many years. So if we can see these kind of benefits developed and brought to our recruits or all of our members potentially, but that level of service and brought to our recruit level so they are more prepared and develop greater resiliency going forward, it's a benefit for our service and for our new members for sure. So we are extremely happy to be involved in it and very enthusiastic about the results that we've seen so far, including some of the aspects of the study that it will allow scheduling changes and possible virtual delivery, because the scheduling obviously for our staff is a consideration as well. So again, very pleased to be involved, and our staff have had great reports of their experiences, as well as our collaboration on the committee. And I definitely see this having a great influence going forward if we can continue to take advantage of those results.
Thank you so much. So that's then this is the acknowledgement. These are the collaborators and staff members and funding agencies for this study. Thank you.
Thank you so much, everyone, for your presentation. So we are going to move on to the third project now. I'm just going to pass over control to that next project so that they can start sharing their screen. And I'm going to introduce the project. So our third project and last project for today is called Compromised Conscience Towards Managing Moral Injuries in Public Safety Personnel. And I'm going to introduce Dr. David Malloy, Professor and Principal of King's College University College at Western University. And he is going to present his co-presenters for today.
Great, thanks so much, and thanks everyone for giving us the opportunity to present today. So with me presenting today are two outstanding scholars, Drs. Lentz and Smith-Macdonald. Dr. Lentz is a postdoctoral associate at Western University, and her research has focused on musculoskeletal and psychological injury in PSP. She's also a former police officer. And Dr. Lorraine Smith-Macdonald is a postdoctoral fellow at the University of Alberta in the Heroes in Mind Advocacy and Research Consortium. Lorraine's clinical and academic career is focused on moral injury and the mental and spiritual health and well-being within the military and veteran populations. Other members of our team that I need to mention, of course, Dr. Nick Carlton. He's a professor of psychology at the University of Regina and the scientific director for the Canadian Institute of Public Safety Research and Treatment. Dr. Greg Anderson is the Dean of Science at Thompson Rivers University. Dr. Rose Riccadelli is a professor of sociology and the coordinator of criminology and the co-coordinator for police studies at Memorial University in Newfoundland. And finally, Dr. Suzette Bromo-Phillips is an associate professor in the Department of Occupational Therapy and the director of HIMARC, the Heroes in Mind Advocacy and Research Consortium at the U of A. So this project arose from many disparate conversations over time with colleagues, academics, and practitioners from topics ranging from PSP to RCMP to PTSD to existential meaning to Socrates and yes, even Homer. And also the power and utility of the humanities. What's emerged is a novel approach, we believe, to the concept of moral injury and how we can address it using therapeutic modalities more common to philosophy than pharmacology. This is exciting and important work that we have, we hope will impact not only the mental health of our PSP, but also the importance of their value and moral awareness and agency writ large. So thank you again, everyone, for inviting us to present. And without further ado, I'd like to pass it over to my esteemed colleagues, Lorraine and Leanna.
Thank you, Dave. So just to start out, we're going to give you a brief context of what moral injury is. It's a construct that's rooted in spiritual, religious, and philosophical traditions. It's a trauma syndrome, not a diagnosis at this point in time. It occurs when an individual's moral conscience is harmed because they perceive or participate in an act of moral transgression, which produces strong negative emotions, potentially including, but not limited to, substantial guilt, shame, sadness, and anger. It can occur with public safety personnel make decisions or take actions or fail to take action in the line of duty that conflict with their internalized values, principles, and beliefs. So common stressors related to moral injury are betrayal, inability to prevent death or harm, ethical dilemmas, just to name a few. And unresolved moral injury can lead to comorbid mental illnesses such as post-traumatic stress disorder, depression, and anxiety, behavioral changes, and substance abuse, suicidal ideation, compromised psychosocial, spiritual areas and well-being, including relationship breakdowns, spiritual or existential suffering, and of course, professional impairments, including burnout, fatigue, and work absenteeism. So our study is a three-phase study. So initially we looked at the current state of knowledge. That initially we were just decided, well, what do we know about this concept in public safety providers, given the most of the information has been done and studied in the military context and in healthcare context. So we initially did a scoping review to examine the empirical research that exists on moral injury in public safety personnel. We're also conducting focus groups to assess the extent of the knowledge of moral injury in public safety personnel. So we're looking at police officers, firefighters, paramedics, and call taker dispatchers. So we're looking to identify specific potentially morally injurious experiences in these groups. And then the final idea is to provide information to inform proactive educational content for public safety personnel and moral injury. So those are all things we're asking the focus groups about. So while we aim to conduct a literature review exploring empirical research examining the occurrence of moral injury in public safety personnel, but we found that there is a large gap in empirical knowledge. So to address this gap, we modified our original review to a scoping review to look at associated constructs of moral injury, such as potentially morally injurious experiences like ethical and moral dilemmas, ethical and moral decision-making, and moral emotions, including guilt, shame, and anger, along with professional, organizational, moral and values, sanctuary trauma, complex grief, and spirituality. So we found 32 studies. Police were the primary subject of most of the studies. We didn't find any on frontline firefighters regarding moral injury, but we did determine that there were 4 dominant themes related to moral injury in this group. So values are a concept of the desirable with a motivating force, so that which is good or desirable or worthwhile that motivates purposeful action. The common values in public safety personnel were the desire to help and to work for the greater good. Public safety personnel are guided by personal values, but yet are often exposed to complex moral dilemmas that incite moral distress when facing difficult ethical decisions. In their professions where there's hierarchical structures such as these, individuals may struggle with locus of control. Given the rank structure, PSP may feel obligated to act on an external locus of control on superior officer commands or strictly within the rules of engagement or operational policy. However, arguments have been put forward that current protocols are often too static to be meaningfully applied in a complex and fluid dynamic situation, and PSP act according to personal norms and discretion rather than those dictated by organizational policies, as these don't deal with urgency and danger inherent in any of the situations public safety personnel face. The second main theme was moral and ethical decision making. PSP are required to make decisions about who will benefit or be hurt because of their actions. Frequently, these decisions are morally ambiguous or complex with no clear or obvious answer. Tension may exist between professional obligations and personal morals of PSP. So one that did stand out was the use of force for police officers. And they're there to protect, but at other times they have to make decisions that they have to use physical force on people to be able to protect the community. And moral agency may be challenged when public safety personnel don't have the authority or the tools to act in a way that is corresponds with their personal morals and directives. The next one is organizational betrayal. So there's kind of what stood out was feeling that different rules apply to different people and that members of organizations are felt that they are treated unfairly when this occurs. So this brings about primarily the feeling of anger, but also unappreciation, frustration, disappointment, skepticism, and distrust. The second one is lack of support. So that's insufficient resources, whether it be personnel, tools, and equipment. Treatment by other professionals. So this one is fairly obvious in paramedics and the treatment they receive on the street by the people they deal with, conflicts with how they're perceived or treated by emergency medical personnel or in emergency units at the hospital. And then medical discharge. So there's a disconnection without the support. If you're medically discharged for PTSD, you're kind of just left and you have to reacclimatize to civilian life while no longer being a part of the PSP culture. The final one that we looked at was spirituality, and I'm going to hand that over to Lorraine.
Wonderful. Thank you, Leanna. So interestingly, we also wanted to explore constructs that are often associated with moral injury, but sometimes distinct, including complex grief, sanctuary trauma, and spirituality. Now, while the sanctuary trauma and complex grief did not pull up any articles, interestingly, spirituality did pull up quite a few articles. Again, as Leanna's mentioned, a lot of this, the articles were focused on policing. And I also just want to say here that when we speak about spirituality, we mean this in a broad sense. This was not specific to any kind of religiosity. This was rather the idea of personal beliefs and values that people hold close and understand as their spirituality. So there was really three key messages that came out of this literature. First, it was that PSP, or in particular police, often expressed their occupational and spiritual language. And what I mean by this is that they very much felt that they had a calling or saw it as a vocation. So they really seemed to deem their job to be more than just a job. It wasn't just a paycheck, but really a part of who they are and in their beingness of kind of how they want to be in the world. The second piece that was really interesting is that there were some studies looking at whether or not spirituality was protective, which it was deemed not to be. Now, this is quite limited, but also quite in line with other studies of spirituality in other populations. But what it was shown to be positively associated with is elements of spiritual growth, post-traumatic growth, self-actualization, and a decrease in psychological distress. So really what this seems to be indicating is that we cannot say that spirituality will protect people from necessarily getting PTSD, but what it does seem to have is a bit of an effect in terms of supporting people when they have become injured to be able to start to move through that and to be able to perhaps move into a growth area. Interestingly, it was also inversely related to alcohol use, so the people who were more spiritual tended not to use as much alcohol, in particular as a coping mechanism. The third point that is perhaps most interesting is that while spirituality has usually been thought about in terms of that protective mechanism, it seems to actually have, in some cases, an opposite effect, which is really to say that PSP work often results in spiritual struggles and erosion. And what we saw quite frequently in the literature was that PSP expressed this in terms of changes in worldviews, existential questioning, and senses of hopelessness and meaninglessness. And so I think really what stands out here is that actually there is an impact to the human person by doing this work, especially again coming from a police culture. And one of the interesting ideas that has not been widely discussed is that this idea of evil, broadly understood, was central to policing. And really here it was the struggle to address how do we deal with these things? How do we make sense of the actions and the horrible actions that we've maybe seen people perpetrate against each other? And so I think this really raises an interesting field of research that's been largely underexplored. So just to wrap up the scoping review, in summary, I think there's really 4 key messages that we want people to take home with. The first is really that moral injury and moral distress seems to be relevant to the PSP occupations. The second is that PSP seem to hold incredibly strong values and are very value oriented. And what we mean by this is that they're very motivated to act congruently within their value systems, both personally and professionally. However, we also know that PSP are frequently exposed to morally ambiguous situations where they're required to make decisions. And some of those decisions may be in congruence with that personal and professional component. And there may also be times when there are challenges with this. And also we want to share that it's important to recognize that these challenges, I think, will come up regardless of the amount of the amount of preventive education we give PSP. And so really it's, I think, speaking to the fact that this is just a component of the work environment in which PSP have to live and function in. The last is just to say that it also seems like associated issues such as the spiritual domain of health and organizational components are also impacting how PSP may understand moral injury, and that these also need to be explored when we think about this construct going forward. Next slide, please. So moving on to the second phase of our study, which is currently ongoing, we are holding focus groups to speak directly to public safety personnel in terms of their understanding of moral injury, and to also ask them about potentially morally injurious events that they may have experienced, the impact of those, and how we can assist in terms of potentially developing some psychoeducational material that then can be used in a preventative manner. I also just want to quickly mention here that we have had some challenges in relation to COVID and how that has impacted our study. We had planned to hold focus groups with firefighters, paramedics, police officers, call takers, and correctional officers with approximately 8 to 10 persons per group. However, given COVID and the incredible stress that our PSP are under in terms of meeting their occupational requirements, we have noticed that it has been difficult to get participants. And we don't believe that this is because people don't want to participate, but simply because of just the amount of stress and work that they are under. And so we have struggled to recruit. And so I just want to offer that as a thought. In relation, if you can just quickly go back for 1 second, just in terms of the focus groups themselves, while we've had limited success, we have had 3 focus groups. And the most important, again, findings to take out of this was really twofold. One, to say that absolutely, when we talked about this construct, it did resonate with the PSP groups. And the second is to say that in terms of the findings about the psychoeducation, it does seem that PSP would like this. And that in particular, they would like 2 approaches to this. They would like to have knowledge about this earlier in their careers prior to starting the job. And in particular, they would also like this to be done very carefully and very safely. And specifically in terms of talking about potentially morally injurious events can be extremely difficult. And so PSP groups have suggested that part of this education should also be for clinicians who may be able to assist them when they come. So as we said, we are in the process and just beginning to wrap up here. We are moving towards phase 3, which is the psychoeducational content. We are hoping that we will be able to address these desires, both in terms of content that will specifically be used for frontline public safety personnel, as well as further organizations, and also in relation to clinicians who specifically work with these groups, so that PSP, if and when they address or experience moral injury, can get support from all 3 levels. Last slide, please. So finally, just in summary, as we wrap up, our grant has been able to do 3 things. So the first is to increase awareness of moral injury within PSP and clinicians. We've also been able to identify potentially morally injurious events within PSP groups. And we are also hopefully going to be able to finish very shortly the creation of proactive and responsive educational tools that can be used to address this issue going forward within PSP groups.
Okay, thank you so much for that presentation. So we have gone a little long today. We had some really great research that was being presented. So I do know, obviously, that there are some of our attendees who are not able to stay with us on the line. However, if there are any questions people want to submit and our presenters for today are okay with staying a few extra minutes, I'm happy to let people ask questions. If any project the people are not able to stay, please just let me know. Otherwise, if there are any questions from our audience, you can go ahead and feel free to ask them. I do have one for project number 1. So if Dr. Ricciardelli or Dr. Mongrain would be willing to answer this question. It's a simple one, but it's a one that I think is an interesting one. The person just asked that you indicated in your summary results that on research after training, so after onboarding, would be important. Is that something that you guys are looking to do or actively pursuing right now, to do that follow-up with people after they've gone through the training?
Yeah, actually, we're doing that actively as we speak. There was a bit of a COVID pause in some of the research because of obviously COVID. So I had completed 10 of 14 weeks. I meant to go back to do primary worker training and finish those additional training. And then part of the onboarding program is going to be evaluated with the longitudinal study that is very much tied to this. So that is something we're going to do. And it's essentially, it's key to see how things hold from the academy into the organization.
Okay, perfect, thank you. Dr. Moda or Dr. Ko, if you are still, I think you're still with us. This was just more a methodological question that someone had asked, but they were wondering with your wait list condition, and they wasn't sure it was clear or not, the people that you had put in the wait list, did they eventually get the treatment as well, or were they always just waitlisted?
Oh, they were, they had an option to receive the treatment after the wait list, after a whole 3 months.
Okay, perfect. Good to know. All right, so I actually don't have any more questions that have been submitted for us today. So I am going to give about 30 seconds to anybody who wants to submit a question. If there are any more questions, otherwise we'll end the session for today. So 30 more seconds. If you have a pressing question, please submit it through the question box, as our presenters are still here and happy to answer your questions. Okay, so since we don't have any more questions for today, I am just going to wrap up the session. I'd like to take this opportunity to thank all of our presenters and knowledge users for, again, being here to share their results today. It's important research, and it was very varied research today. Lots of different topics, lots of different aspects of PSP mental health being explored, which I think is really important. As we reach the end of our session, we want to ask you to complete the survey that will appear at the end of the session. You'll receive a follow-up email tomorrow with the video of today's session. We will also be continuing the post-traumatic stress injury series on January the 14th. If you haven't signed up already, the link is available on our website, and it will be in the follow-up email with the video. Again, thank you for being here today. Please take care and stay safe. And since it is our last webinar of the year, I'd like to wish everybody season's greetings and happy holidays from everyone at CIPSRT. Have a great day.